Hello, a very warm welcome to you. Thank you for joining us. This is Platform. I'm Ruth Aguela. Effective public health for any nation is critical, as it does not only function to provide adequate and timely medical care, but also to ensure tracking, monitoring, and control when there is disease outbreaks. The Nigerian healthcare, no doubt, has recorded several disease outbreaks year after year. Now, the COVID-19 experience, if we recall, shuts down the world, but with sustained efforts, nations were able to bounce back, Nigeria inclusive. As a nation, we keep experiencing different disease outbreaks, from Lassa fever, avian influenza, cholera, Ebola, and the latest Marburg virus, that is the monkeypox. Hence, the need to tackle the challenge through sustained capacity response. That is where the Nigerian Center for Disease Control comes in, an agency we know under the Federal Ministry of Health. Its goal is to protect Nigerians from the spread and impact of communicable diseases through the coordination of public health, preparedness, surveillance, laboratory, and response functions for all infectious diseases. But you ask, how has the center been able to sustain responses in the country in the face of threatening global health crisis, especially towards the prevention and control of diseases? Our focus on Platform is Nigeria's health security efforts, and our guest is the Director General, Nigeria Center for Disease Control, NCDC, Dr. Ifedayi Adetifa. Thank you very much for joining us, Doctor.
Thank you very much for having me.
Right, so before I introduce our panelists, we'll take you through a bit of his profile. Dr. Ifedayi Adetifa received his medical qualification from the University of Ilorin, Kwara State. He had his master's in epidemiology at the London School of Hygiene and Tropical Medicine, and received his PhD also in epidemiology from the University of Amsterdam, the Netherlands. He completed clinical specialty training at the Lagos University Teaching Hospital, for which he was awarded the Fellowship of the West African College of Physicians in Pediatrics. Dr. Adetifa is the second Director General of the Nigeria Center for Disease Control. He is a pediatrician and epidemiologist with almost 2 decades of work and experience in general pediatrics, infectious diseases, and infectious disease epidemiology. In the last 7 years, he has focused on vaccine epidemiology research. He has also been involved in the COVID-19 response as a member of the Kenyan SARS-CoV-2 Serology Consortium. He is a member of the World Health Organization, Africa's regions, that is for WHO, Afro-Regional Immunization Technical Advisory Group. There's more. I think we should leave the profile there. But thank you once again. Very impressive, I must say, talking about your profile.
Thank you very much.
Okay, our panelist on Platform today is Rabi Abdallah, our head of desk here for Health, NTA. Thank you very much, Rabi, for joining us.
I'm glad to be here, Ruth. Thank you.
Always a pleasure. All right, so Dr. Adetifa, once more, we're looking at Nigeria's health security efforts. We've seen a lot happen in the country now, not just for Nigeria, in the global community. When we talk about COVID, when we talk about, for us now in Nigeria, the Lassa fever, Ebola, and all of that, outbreaks of disease is something that is inevitable. But management in terms of response, preparedness is critical. And the NCDC is tasked with that responsibility to ensure that we are safe and sound. How far so far when you want to paint a picture in assessing Nigeria's management in terms of response?
Thank you very much for your question, and of course the head swelling inducing profile. I just also like to point out that I am the third director of the NCDC.
Okay.
You have to remember that Professor Nasidi was the inaugural director.
Okay.
Well, the NCDC, when you ask about how far so far, I would say that the NCDC has done well in living up to its mandate to prevent, detect, and respond to communicable diseases as public health threats. And I will add some more context there. This is a relatively young agency. Actually, act to establish it was only signed into law 5 years or so ago, but it has had to both crawl, run, and sprint at the same time together, because the pathogens to which we are responsible for do not operate by a calendar. Yeah. They do not say, oh, let's give you time to get ready.
No.
They strike when they strike, and you have to both prepare and respond at the same time. And that's been the challenge for Nigeria's emergency preparedness and response. It's that we have not had any breathing room to actually spend time to, under much controlled conditions, to put in place all of the stuff that we need in terms of preparedness and response. But it's also important to highlight, because everybody thinks more about response, and actually the adage prevention is better than cure. It exists for a certain reason, that
Sure.
There is need to put in place measures that contribute to prevention, measures that contribute to early access to clinical care, early treatment. So I'd like to highlight that our mandate is fully dependent on having your basic healthcare system functioning, from primary healthcare and above, and actually having that fully functional is what produces the resilience that allows you to bounce back when you have been briefly knocked down by, say, COVID or other outbreaks, as the case may be.
Okay, Dr. Adetifa, we know that diseases know no borders, right?
Absolutely.
At what point are outbreaks, okay, given that seriousness it is usually given? I'm asking this question because I know that some regions have peculiarity. I'm looking at it from the perspective of the African continent, and of course, coming down to Nigeria, we have our peculiarities. For instance, year in, year out, we experience cholera outbreak, right? And like we are in the rainy season and the flooding period is here. The question I've always want to ask, and I've always pondered over, it has to do with if preventive measures, like you said earlier on, preventive and not reactive should be a priority, right? Why do we always wait until we're having cholera outbreaks before we swing into action? You know why I'm starting with cholera? Because we are in the season, and I know that I already feel us. Why are we in such a situation?
The problem with cholera is one that indeed keeps me up at night, because we know the solutions to cholera. And indeed, in other places, cholera probably still happens under situations of humanitarian crisis and war and the like. Yeah. We know some parts of the country have been affected in that way, but we know that for other parts of the country, even places down south, we are unfortunately seeing the manifestations of what would be long-standing neglect in terms of investment in water, sanitation and hygiene. Provide clean, potable water, safe management of sewage, cholera will disappear. Wow. So that is the challenge. Now, some of you, if you are like me, I can really sort of chart my experience in the country from when you had regular pipe-borne water supply from the public works in your house to when it dropped to maybe once a week, or you have to remember to get up at night when the taps run to quickly fill up all the containers. And then you got to a point where water simply stopped running. Okay, what then happened is, of course, many of us are also quite privileged. We made alternative arrangements for our water supply. Now, our citizens who are not so privileged do not have that opportunity. They have to depend on rivers, ponds, and all of that. They don't have water closets or safe latrines for
open defecation.
Yeah, there's a lot of open defecation. Yeah. So what happens is, okay, that is okay. Everybody is fine during the dry season when wherever you defecate still remains separated from wherever you get your water. And then the rains come and mix up everything and contaminate the water sources, and then the cases begin to arise. And then in some parts of the south, especially despite people thinking that in general some places are better, you do have underserved areas, those places along the creeks, for example, or that are fairly isolated, that don't have potable water supply, and also now are reporting cholera cases. So I know that there have been efforts, both driven by policies of the federal government in terms of water sanitation, and even encouraging states to do that. But as I've just told from my personal experience, there's been a long-standing lack of investment in expanding water works, expanding piping, city development, and all of that. And then it's impossible for any government in an 8-year period, if they're lucky, for 2 tenures to solve all of that problems. But we need more investment in that space. And
picking a cue from what you just said, of course, while we await implementation of policies that will address some of these problems, in the area of preparedness, we know these are occurrences, from what Rabi said, that happens every year. Flooding, it's inevitable. Now, these people, this is their means of livelihood. They get their water for cooking, for drinking, for bathing, and they defecate in it. If we want to look at the area of sensitization, because we have to nip the problem in the bud before we can talk about response. How much sensitization is done at that level, at the foundation level, to ensure that preparedness is guaranteed?
That's a question that will be easier for state governments to answer, because that really is in the hands of state governments and local governments to look after both the prevention and the sensitization and preparation in their local context for water. Certainly, I wish I could, in some way, marshal tanks and jerry cans of safe water with approximation of how much volume you need per adult, and just move them into the communities ahead of the rains. But the national government can't do that. Besides, it's not the job of the federal government to provide water supply in any state per se. We can make enabling policies, facilitate development process with also credits and all of that, but this is still primarily a state and local government issue. And we have tried. I mean, I go to meetings of the National Economic Council, which has the governors and the vice president chairing, and I've talked about and still talk about cholera, both in advance, encouraging the need to invest in water and sanitation to be able to see a difference in what happens to cholera when the season comes. And there is some movement in that space, but as I said, when the Gulf is pretty big across large geographical area, dispersed population, you really do have to work really hard to overcome decades of neglect.
I'm sure there have been platforms, or there are platforms where you get to engage with this state governments. And what are some of those challenges they get to tell you? Because if, for instance, we have roles, the federal government has its role, the state governments have theirs, local governments have theirs. And if one segment is seen to be falling short of its role, it affects whatever efforts is being put together, at the federal level.
Yeah.
So a whole lot of gap, revolve around states and local governments. Are they mindful of this?
Well, I can't speak for them, but I would think that they are. Also, I'm not defending anybody, but I'm also aware that we are now talking about cholera, water sanitation in Nigeria, and this is one challenge in a long list of challenges that you must prioritize for response against, which is counterbalanced by a limited or finite source of resources. So it's, if you're coming out of a pandemic when national revenues have dropped and state revenues have dropped and maybe the economy suffered an impact, then that definitely filters down in terms of how much revenue every state or local government gets. And you have to do water, sanitation and hygiene, but you also have to look after education, you have to look after health. So they are competing priorities, and I'm sure that they are trying to navigate their way through balancing that. But there is need no doubt, and that's the message I will continue to preach, for substantial investment in the water, sanitation, and hygiene space, and not just for cholera. You're going to have knock-on effects on other diseases. You're going to be more healthy.
Yes,
you're going to be economically productive. You're going to spend less time in hospital. People are going to live longer. So perhaps from a financial perspective, if we can also make very clearly the economic arguments, because sometimes people, infrastructure projects tend to appeal. The ones that appeal tend to be the ones you can see, so roads or buildings projects and all of that, you know. And it's difficult, and you can talk about, okay, farmers will get their produce quicker to town. Often the health security investments or investments in health, their benefits do not immediately compute to a balance sheet. And we, of course, all have to do better to actually relate the economic benefits of actually investment in health security or in basic health care, as the case may be.
Does it in any way, talking about financial gaps, affect the operations of the NCDC?
I would say yes. You know, immediately I would also say that I know this week I had to sit down with honorable members of the House our Oversight Committee and look at NCDC funding over time. And with credit to government, these are steadily increased over time. Yeah. Okay, but you know, you say it's steadily increased over time, but does it meet all your needs or all the aspirations that we're supposed to, all the things that we're supposed to be doing now? That's an area of growth. But the government certainly can put up its hand and say, look, we have steadily given increasing money, both by appropriation and by intervention, to allow us to achieve a lot of the things that have been done. But as I said, this is an area where that did not previously receive enough attention, or in fact, nobody knew about the NCDC before these more frequent outbreaks. So, and that also is probably reflected in the level of previous investments, which were maybe focused elsewhere.
I know that funding, when we talk about funding, a lot have been done towards improving funding for health security. That I'm aware, especially with the pandemic, the COVID-19 and all of that. But we know that some of these outbreaks are seasonal. If you have measles, we know the period for measles outbreak. We know the period for cerebral spinal meningitis outbreak. We know the period for cholera outbreak and all of that. That, you know, I'm still taking you back, you know, where states are concerned now. And since you coordinate, you know, some of these activities, you know, mitigating activities and all of that, when you get to sit, you know, around the table with these people, I'm talking about preparedness now. Because we will see them coming, like Ruth had said at the beginning, that these are things we know would happen. Yeah. They would definitely happen. Because sometimes they are minimal. Those outbreaks are minimal. And of course, if they are minimal, it means whatever preparedness you've had, it means less of it, or even if it's funding, less will go into it. But do you have that preparedness in such a way that you've already, you know, mapped out those areas, yes, and you saw these are the red zones. These are the zones that the states that are prone to so, and as such we should be prepared for this. I don't know. Don't you have such arrangement in place?
We definitely have such arrangement in place, and we already start sensitizing state colleagues, epidemiology teams, public health teams, professional groups, and anybody concerned about, say, you know, Lassa fever is coming. Please, you know, take note. We do surveillance, for example, for healthcare worker infections, which is often an index sign that Lassa has started, because, and then, of course, along with sort of advisories and preparing state teams and responding to their needs, either for specific training or to deploy teams, we also stock countermeasures in the national stockpile in preparation for deployment should it be needed. So treatments, PPE, and all of the other things that are necessary. So certainly we know where the hotspots are for particular conditions. We prepare. We've got technical working groups for all of the diseases that are under our purview, and in fact technical working groups in preparation for diseases that may just turn up. And these working groups in the background actually look after the diseases they're responsible for. You probably only hear about them when we activate a disease-specific EOC, which means that we've moved to a heightened level of response based on a risk assessment. So TWGs or technical working groups are always there in the background. When there's a problem or the need for escalation of response efforts and all of that, then they become an EOC. So that's actually what happens. Okay,
I'm glad you just mentioned the Lassa fever. So let's begin to break them one by one. And according to a report by the center that for the year 2022, there is about 70% of Lassa fever outbreaks, mostly high from 3 states, that is Edo, Ondo, and Bauchi. Now, since you've talking about mapping out strategic areas that are, vulnerable to this kind of disease, what has been done in terms of containment in those zones, those red zones?
Well, Lassa fever is a peculiar peculiar condition, really concerning, because one, it's a virus is transmitted by a particular type of rat, multi-mammoth rat. It typically, starts to come into human habitats in the dry season because, of course, the bushes are dry, or we burn down the bushes. And then because we've burned down their homes, they come and reside in our various hotels that we also live in, and then contaminate our food and food sources. And, of course, some traditional food processing, like drying food by the roadside that we see when we are traveling, and all of that provides an opportunity for, not just this one, all sorts of animals or rodents to feed on them and contaminate that. So, of course, we've always given and continue to give sensitization messages about safe storage of your food, do not dry food on the road, and, of course, prepare for disease, avoid the animals, avoid contamination. And if you see anybody with a fever that's not responding quickly to treatment of the usual, please have a high index of suspicion so that we can catch cases early, list the contacts, and hopefully interfere with the outbreak. And we make that plan every year and implement today. So various extents to which the states can. There has been some gains. I mean, of course, Edo, Ondo are the key centers and have basically specialist units for Lassa fever now, so much so that they actually do quite well in their journey towards our target reduction for case fatality rates. But we've also, increased surveillance and network laboratory capacity to diagnose, because we know that the fact that places are not reporting do not always necessarily mean that they don't have. Okay, so part of why we're seeing more Lassa fever, for example, is that we've moved lab network size over time from 4 to 6, and then in this year to 8, just to increase the opportunity to diagnose, so that maybe those cases that previously may not have had a sample taken or investigated because nobody's thinking, oh, we can't send to Abuja, so there's no point, can now be done closer to, and all the hospitals are mapped to particular labs to send their samples to. We also have working with partners, because we need positive disruption in the Lassa fever space. We can't keep, I'm personally tired of wash, rinse, repeat. So we're looking into development of vaccines, development of new therapeutic agents. Irua in Edo State is really now a center of excellence for Lassa fever care. They are very good at looking at Lassa fever in pregnancy, lactating women, and really managing the cases well. In fact, the CMD was saying the other day that, he doesn't remember when last day, for example, they lost a healthcare worker to Lassa fever, because they are now really that good. And that's an example that we would like to replicate across the country. But the IRA journey has been 15 years, 20 years long. So, yes, we don't expect that everywhere should take the same length of time, but a point is that it doesn't happen overnight. But as we can see, FMC is playing catch-up. Doing quite well. I've actually been there since I resumed. We've also got the Federal Teaching Hospital in Ebonyi also doing its own role. But with increasing diagnostic capacity, we are now identifying new hotspots. So Benue in the past year, Adamawa and the likes. And it's not just about diagnosis also, it's also the expertise to manage associated complications, because Lassa fever really requires supportive treatment. If the kidneys go, then you need to be able to dialyze. To be able to dialyze, you need to have a dedicated dialysis machine for infected case, because once you don't want to put your Lassa fever patient on the only dialysis machine you have when sort of your normal chronic renal cases are going to come and you put them at risk of infection. So unfortunately what happens in some places is that they have to refer the patient just for dialysis, maybe from Benue to Irua, to Ebonyi, and that or to Abuja, that unfortunately contributes to really poor outcomes. So the NCDC, as a response to that, has had to sometimes actually procure dialysis machine as part of response and supply and give to some of the hospitals. But
from your assessment, would you say Nigeria has the capacity to to deal or contend with some of these diseases? Well,
we do. They haven't sort of taken over. If you had a completely poor response, you would have widespread, impact on. So that is happening. What I'm saying is that our aspiration is to grow beyond containment. Is that we really now want to achieve positive disruption in the space, especially for some of the conditions that continue to challenge us, and Lassa fever is one of them. So if we can, with the new investment and new attention, can finish this research that helps us to better understand the study. For example, we don't have any evidence of what is the best way, for example, to get rid of that rat.
Exactly, because I was just going to take you up on this.
Do we?
We work with the Federal Ministry, our colleagues in the Federal Ministry of Environment to conduct sort of deratization exercises, but without being able to understand, okay, how does the rat even get the virus? How long does the rat live with the virus? Okay. If these rats reproduce every 30 days, it means the moment you go and kill all of them, by the time you travel back to Abuja, there's a new batch already.
True. Okay, let me hold your thoughts there. We're just going to take a break. I know Rabi wants to pick up from where you left off. Yeah. So let's go on a break. We're back.
Sees that the Buhari-led administration has made remarkable progress,
like Lafia Transmission Station nearing completion.
Africa does not need charity, but partnerships that will promote the adequate investment
with the cooperation of all.
Sharing firsthand the experiences of reporters on the field as they bring to you weekly the beauty of Nigeria's diverse culture and the economic potentials therein. The Correspondents, development through the eye of the grassroots, showing every Monday at 1:30 p.m. on the network service of the NTA, with a repeat broadcast on NTA News 24 and NTA International. Join us.
Now, what could make someone set out on a journey and not get to his or her destination?
Extremely important.
Imagine a victim who cannot reach out to these responders, who doesn't even have the phone to reach out. Hello, thank you very much for joining us on platform. I'm Ruth Aguela.
And the girl, especially if the girl is a minor, she's not yet 18 years, if she gets pregnant, realize that such girl is sent out of school and the boy is left in school.
Just park to pick the call.
So how much sensitization is the FRS?
I don't agree. A lot of people are just deaf.
Welcome back. Thanks for staying tuned. We're still looking at Nigeria's health response efforts, security rather efforts, and we have Dr. Adetifa here with us, the DG NCDC. Now, you were talking about how we can phase off the rats. Is that even possible? Rabi, you want to pick up from there?
Yeah, listening to you once again took my mind to the importance of research. And it's research that could make experts to figure out why this is this and what needs to be done, right? How much funding is being, is going the way of research, talking about the component of preparedness, response, and all of that? Is it much of a priority in the nation's health security?
It is a priority, and starting with the ideas of the founding fathers of the NCDC and the legal act, we are actually mandated to conduct public health research to help inform what we do in terms of preventing, detecting, and responding to these communicable disease threats. The funding for that is relatively small compared to some of the other funding. At least the fraction allocated to, in our proportion allocated to research is relatively small. But still enough, as I tell my team, to allow us to do little bits of work that will generate either hypothesis or answers to the questions that we need. And this is an area of priority for me as the NCDC DG, given my sort of more slightly academic leaning backgrounds, but also fits into the overall outlook or the overall strategy of the NCDC is that actually for all of these conditions that we look after, we are mandated to, but we also, as a matter of philosophy, look after them from a One Health perspective, which means we've got to, this is a Lassa fever outbreak. What's the contribution of the environment? What's the contribution of the animal health part of that? And we know that if you look at Lassa fever, look at monkeypox, look at COVID, where we can talk about Ebola, even Marburg in Ghana, yellow fever, they all have something in common. They are all zoonotic illnesses. These are illnesses that are caused by pathogens that primarily affect animals, but at some point in time, they are able to make the jump across what we call the animal-human interface in the environments that we share. And then some of them are able to adapt to, they decide we are actually like 5-star hotels compared to their natural host, and then they adapt to,
because they get to see variety.
Yeah, so they adapt to us and then cause us a whole world of problems. So we take a One Health approach, which is why we go out with colleagues in the Federal Ministry of Environment who, as experts in the environment, look into different ways to conduct deratization, but we are now quite interested in actually now studying with our animal health counterparts the rat itself to understand what areas in its either its life cycle or in its behavior are going to be amenable to public health interventions. Because actually, if you could just, well, the ideal thing is if you could read the rats of the virus, that would be perfect, because it's difficult to, people think, oh, why not just eliminate the rats? But the rats play a role in that ecology where they occupy. You do not know what would happen if, for example, you overnight or at the snap of your fingers, I could wish all those rats away. We probably will see some other animal or other thing that the rats have been helping us control suddenly become a bit of a nuisance in the environment. But these are some of the priority areas that we are interested or applying some of our more limited research funding into. But we are also lucky to have, opportunities for support and collaboration with partners who, people like the US CDC and all, who also, are able, to the extent that it's possible, bring on board, teach us new techniques to, we've not been doing this thing all the while, so sometimes you need to learn new ways of trapping animals, of conducting the sophisticated tests that you need to do with them. And to also mention that apart from the, speaking about the Federal Ministry of Agriculture and Rural Development, we do work closely with our counterparts in the veterinary section, indeed the Chief Veterinary Officer of the country, and with the Premier Animal Health Research Institute, which is the NVRI, in some of the things that we do.
Okay, let's take a look at yellow fever now. How are we doing with the eliminate yellow fever epidemic strategy? Yeah,
so the I strategy as it is I think rests on three. So the last one is to sort of avoid cross-border exportation, but then to protect the susceptible population, and then the first one is to achieve high vaccination. So yellow fever, measles are outbreaks that we are contending with now, especially measles in the last couple of weeks. And these are vaccine-preventable diseases. They've had vaccines that will protect you for the rest of your life with one dose or 2 doses for years. In fact, the problem we have with outbreaks of vaccine-preventable diseases is vaccination coverage. And you know that there have been historical challenges across the country in terms of vaccination coverage that have been tackled head-on by our sister agency, the NPHCDA, through the Ministry of Health and other partners, including even receiving the highest level political commitment, including commitment, especially in the context of polio from private sector. There's been progress. I mean, I don't know if you were at the launch recently of the National Immunization Survey results. Yeah. So we moved from, sort of having just a little more than a third of our under 5 children being fully immunized to 57%. It's a significant jump given where we start from, but we're still a long way from utopia. Because if you think about a condition like measles, you need to have 95% coverage. Yeah. Because measles is actually, the measles virus is probably one of the most infectious pathogens around. Every case, even under normal, whatever, is likely to infect 18 to 20 people. Yeah. Then when you add deprived conditions and all of that, is even worse. So this is where the investment needs to happen. We need advocacy, we need community engagement, community leaders, religious leaders, political leaders, all sorts, everybody that is required to provide the education and the sensitization that is required for people to take their children to receive immunization.
That's why I said it boils down to advocacy. Because if people are aware of the disadvantage and the advantage of getting vaccinated and the disadvantage of not getting vaccinated, because children are
I'm afraid it's not that simple, honestly.
Why?
Because I don't know why, and this is where the human behavior is a strange one, and actually having the correct knowledge doesn't always lead to behavioral change. I can tell you that most people who smoke know smoking is bad for their health.
Of course.
Okay. And I can tell you that, people who live in many communities know that somehow this condition that is killing us is not affecting some people, but for various reasons, either the part where maybe a lack of...
term it lifestyle?
Well, actually, it's a mixture of reasons. So there's vaccine hesitancy for cultural, for religious reasons. That's one block. Okay? There are those who unfortunately may have live in situations where it is indeed challenging to get to a primary health care center. As you know, the Federal Ministry of Health again and NPHCDA are started this PHC revitalization program. This is part of the effort to make sure that we bring basic health care close to people. The philosophy behind primary health care, or the aim really, is to have, to the extent that's possible, we have a primary health care center in every ward. So within 5 minutes of walking, because we already know that from data that distance from health center is inversely proportional to vaccination coverage. The further the person has to travel to get to the health center, the less likely they are going to complete the immunization schedules. And the ones that tend to be affected are the ones that are given later in the baby's life. So all those 9 months to 12-month-old vaccines, measles, yellow fever, the coverage really drops down. So when the child is young and mother has not completely gone back to full economic activity or looking after everybody, those first 14 weeks, they tend to get those ones. Then
later on, there's no will.
Okay, so before we go beyond the boundaries of Nigeria now, because we've been talking about those ones that really, really affect us in country. Let's conclude by you telling us, between yellow fever, measles, cholera, meningitis, monkeypox, which among these ones that could be, referred to as, outbreaks that are indigenous to us, so to say, or synonymous with us, so to say, to some extent, constitute the biggest challenge to us today? If I ask you about yellow fever, what would you say?
Sorry, Rabbi, nothing is synonymous to us. Everybody, countries in history have had cholera or,
But some countries, report this things more than others.
Oh yeah, for obvious
that's
reasons.
That's what I'm saying. Our indices are not that good. That's
true.
That's what I meant.
Yeah. So, as an agency responsible for looking after these things, and I've said this before, all of those conditions are of priority to us. So, what is making the headlines or the news or the newspaper pages do not reflect our priorities. Okay. If you remember, one of the first things I said when I turned up.
I'm glad you're saying that.
Yeah.
Yes.
One of the first things I said when I think my first interview either here or elsewhere when I first resumed is that. Honestly, we are not. I know that we've become known because of COVID, yes. But I reminded people that we're actually not a COVID agency. And I remembered making the case that, look, cholera is competing neck to neck with COVID in terms of the number of people it has killed, yes. But it's not receiving the attention. And I am appealing, and I was appealing that, look, you need to
It was
bring,
here. It was in the studio, yeah.
So you need to bring cholera to the fore as well, and hope that it receives we get as many advocates and other partners recruited to tackle it. But we respond to all of these conditions. Now, the challenge that we have is, yes, you've got the same team dealing with concurrent outbreaks. So you talk about workforce capacity, which needs to be expanded. You have people who have been responding to COVID for 2 years who are fatigued. True. So in these and sort of other areas, including the resources, are where the challenges are. So it's not that we are not lacking in will to tackle all of these conditions, and we prepare for all of them. We have technical working groups for all of them.
But we go after those ones that are more critical or more.
No, when you need to respond, you respond. Mm-hmm. But we do not, because we are responding to cholera now or to monkeypox now, we are not ignoring Lassa fever. And we are not ignoring meningitis. And I think the state epidemiologist or our colleagues in the states can confirm that. I get all these requests for everything.
So what can you tell us about the Marburg virus? What's the latest update?
Well, the Marburg, we did not have any case in Nigeria, thankfully. We were prepared for the possibility that it may arrive. In fact, as I said before, prior to the case happening in Ghana, we've always made sure we had capacity to diagnose Marburg in country, because it's on the list of priority conditions, epidemic conditions that you need to worry about. The Ghanaians our colleagues in Ghana now seem to be on top of the outbreak. In fact, they are now counting down to the end of the outbreak. I'm not sure when the 42-day countdown they are now, but the very last of their contacts are exiting quarantine. So we hope it stays that way. The virus is a virus we don't want any virus, but Marburg is the only other virus that belongs to the same family as the Ebola virus. They are really nasty viruses that have really high case fatality. Unlike Ebola, there is no vaccine, there is no curative treatment for it at the moment.
So we don't
have Marburg. Okay. Marburg is not monkeypox. These are all different viruses. So I know that people tend to mix up pathogens, and maybe not. You can't be the people. I mean, people in my village may not necessarily. Old people in my village may not necessarily understand the difference between bacteria and viruses. And indeed, in my language, they are all insects. The insect that causes something, except that you can't see it. But cockroach, something, that's what we say.
Wow. Yeah. At some point, monkeypox dominated the headlines. People became apprehensive. Monkeypox wasn't new to us. But all of a sudden, it became a very, very, serious issue that people, that got people talking. We even had the allegation that, that some countries said it originated from Nigeria, just like China was associated with COVID at the initial stage of the outbreak. What can you tell us about monkeypox and even those informations we got about
monkeypox
and the Nigerian situation?
As you rightly pointed out, monkeypox has been something the NCDC has been responding to since it re-emerged in 2017. So first case of human monkeypox was in 1971. We had a few sporadic cases, I think up to 1977, 78, the 40-year gap. Then we started to have cases in 2017. Of course, in fact, the monkeypox re-emergence in 2017 was one of the drivers for the deployment of our digital surveillance system, SOMAS. It gave us additional impetus to roll that out. And then we've been dealing with that every year for the last 5 years and reporting on it and increasing our capacity. So we went from not being able to diagnose it to being able to diagnose it and being able to sequence it, which were not possible in the first few years of the outbreak. And we then consistently reported data on monkeypox, which is why we receive all the attention.
But there's a concern by the Center of underreported cases because people confuse the infection for chickenpox.
It is true, and we do know from testing that when we get suspected samples, almost equal numbers test positive for monkeypox or for chickenpox. And indeed, what we are doing now, even at the last monkeypox EOC meeting, is we are now going to revise the definition of who is suspected cases to include the possible, whatever people think chickenpox is. Every chickenpox case really should be investigated for monkeypox. And we say that because the data we have suggests that they are both being mixed up. And then there's a small group of people who have both conditions.
Both chickenpox
and monkeypox. And they seem to be at a really high risk of having severe disease and perhaps even dying. So it's important that we include chickenpox in the case definitions, because it is possible that one, the chickenpox may actually be monkeypox, or two, you may actually have a co-infection. And if you have a co-infection, then it means that we have to look after you slightly differently.
Just for people who don't know, can you educate just very briefly, what is the cause for the monkeypox?
Well, monkeypox, chickenpox are both caused by viruses, and they are completely unrelated viruses. They both cause a rash or eruptions, as we call them. To the layperson, they might be difficult to differentiate, but monkeypox tends to be preceded by what we call gland swelling in just beneath your jaw and in your neck, and then the lesions start from the face and spread downwards. They also tend to they may affect the palms and the soles of the feet, which almost never happens with chickenpox. I did have chickenpox as an adult, so I know.
We've all had. I had chickenpox
as an adult. No, mine was not as a child.
So they tend not to affect the soles and the palms. That's chickenpox. Monkeypox does affect the soles and the palms. And then you may have an unusual distribution of the lesion around the genitals as well. But ultimately, if you see them, please call the state or local government authorities, have a sample taken. We will provide diagnosis, and then we will know.
Okay, Dr. Adetifa, we're rounding off. We just want to hear your final thoughts.
Let's talk COVID.
There's no time. We're rounding off. So, but as part of your final thoughts, tell us what Nigerians should know and do in terms of prevention, which is key before you're talking response. All encompassing, including COVID.
So I think it's important to highlight to fellow citizens that we are having avoidable challenges to public health. And I say avoidable because outbreaks of measles, of yellow fever are preventable by vaccination. So please get your child vaccinated. Participate in vaccination campaigns when they come around. Beyond yourself and your family, please look out for your neighbor, look out for others, and be an advocate for vaccination, because what happens to your neighbor ultimately will affect you. COVID is still with us. We've achieved a lot of disconnection between COVID infection, hospitalization, and death through both natural immunity and especially through vaccination. So please make use of every opportunity that the government has provided to get COVID vaccination.
Are people even still doing tests? Are
people are still doing tests. Tests are being done. They are not at the levels that we want them to be, but from sometime from week to week, some states actually hit their testing targets.
I'm
So the
afraid,
results are
Dr.
reliable.
Adetifa, I know there's so much you want to tell us, but our time is up. Thank you very much for educating us and enlightening Nigerians on the need to take care of their health. Prevention, of course, is key. Thank you.
Thank you for having me.
All right. Rabi Abdallah, there's so much you want to talk about.
Honestly.
We're done. Thank you.
Thank you so much for having me.
All right. So we've been talking about Nigeria's health security efforts. There's so much the NCDC is doing and wants to continue doing, but you know that your health is in your hands. Let's do the needful. Prevention, they say, is better than cure. That's Platform. I'm Ruth Aguilera. Bye.